Good afternoon, everyone. You're most welcome to the second webinar series, the second session in our webinar series on skin NTDs. We'll be starting quite shortly. If you'll just allow me to add the panelists, we're going to be talking about cutaneous leishmaniasis today, which is it's not so common in the whole of Nigeria, but some parts of Nigeria do experience quite a number of cases, and a lot of times they go undiagnosed or misdiagnosed. So it's important for us to actually know what cutaneous leishmaniasis looks like and how to treat it and how to report it. So just give me a few minutes to add our speakers. Today, Dr. Nafisa Abdullahi is going to be the one to discuss with us. She works in Katsina, has had experience in Sokoto, where there are quite a number of cases of cutaneous leishmaniasis reported. And please, if you have questions or comments, contributions, please put them on the chat, on the Q&A session, the Q&A box at the lower part of your screen. And we're also going to, we've invited a lot of people from the Pharmaceutical Society of Nigeria, because we know that many times community pharmacists are the first people to see some of these skin conditions. So it's for everyone to know what they look like so that, we can raise alarm and have them properly diagnosed and treated. So you're most welcome, everyone. We're very happy to have almost 80 people on the call already, and we're expecting a lot more. Dr. Nafisa, are you here already? I can't see you yet, so I can add you as a panelist. Okay, great. I found you. Yep. Let me know if you can speak yet. Dr. Oiwo, are you on the call so that I can include you as a panelist as well? Okay, are you able to enable your screen, Dr. Nafisa?
Good evening, Dr. Cole. No, I'm not able to share my screen. Host disabled participant screen sharing.
Okay, I'll do that just a moment. Okay. Okay, can you try it now? Can you try to share your screen now? Awesome. What about your video? Because we had that issue the last time as well. Are you able to share your video? I mean, open your video.
Can you see me? Can you see the screen, please?
Yes, I can see. We can see the screen.
Excellent. I wanted to sort out the screen first before the video.
Okay, that's fine.
Can you see me now?
Yes, we can see your lovely face now.
Okay, thank you. So let me change it to full screen mode. All right. Can I begin?
Yes, please go ahead. Thank you.
Thank you. Good evening, everyone. Well, welcome to the second session on the series for healthcare workers training on skin neglected and tropical diseases. My name is Dr. Nafisa Abdullahi. I'm a consultant dermatologist with Federal Teaching Hospital, Katsina. I'll be taking us through cutaneous leishmaniasis. Permit me to start with a disclaimer that the time allotted wouldn't be enough to discuss it in depth, but at least we hope that by the end of this discussion, we'll have better knowledge of what cutaneous leishmaniasis looks like, how we treat cutaneous leishmaniasis, and also how to go about reporting cases of leishmaniasis. So this is just the beginning of the slides. Okay, before I go ahead, this discussion is brought to you courtesy of the International League of Dermatology and International Foundation for Dermatology and the Nigeria Association of Dermatologists. These are their logos, and a big shout out and thank you to all of them. So this will be the outline of our discussion today. We begin with introduction, move on to microbiology and life cycle, epidemiology, clinical features, differential diagnosis management, and we end with case reporting and integration of leishmaniasis into the national NTD program. So as an introduction, leishmaniasis was one of the skin-related, sorry, if I said leishmaniasis, I'm referring to cutaneous leishmaniasis. There are actually two forms. We have the cutaneous leishmaniasis and the visceral leishmaniasis. Both of these are actually skin-related, neglected tropical diseases, but our interest is in the cutaneous leishmaniasis because that is what we have commonly in Nigeria. And the cutaneous leishmaniasis is one of the skin-neglected tropical diseases, mostly seen in Africa, Asia, and South America, although there are some pockets of patients that are seen in Southern Europe and also part of North America. Then it's caused by protozoa called Leishmania species. They are a heterogeneous group. There are so many of them, as we'll see in the next slide, and it's transmitted by bite of the female sandfly, not the male sandfly. So the female sandfly bites human beings and transmits the disease. And this disease commonly affects the skin, but it may also affect the mucosa and also the reticuloendothelial system. That is the liver, the spleen, and also the bone marrow. So leishmaniasis comprises a complex group of diseases that result from infection with heterogeneous group of protozoa species that belong to the genus Leishmania. It is typically classified into two, the New World and the Old World Leishmaniasis. And this classification basically is, depends on the geographical region of the world we're talking about. New World Leishmaniasis is usually seen in Asia, Southern America, while Old World Leishmaniasis is mostly seen in Sub-Saharan Africa and also still some part of Asia. This is a slide showing the different species depending on which part of the world we are dealing with. Now, this is important because the response or sensitivity of the organism to medication depends on which organism you're dealing with. So the medication that you're going to use depends on where in the world you think the patient has gotten the infection from. So that is why this slide is quite important. As we can see, we have Leishmania donovani, mostly seen in Northeast India, Bangladesh. L. infantum, this is the one that causes visceral leishmaniasis. You have L. donovani, which we usually see in Africa. We also see L. major in Africa. We also see L. tropica, but it's mostly seen in Arabia, in Asia, and also L. ethiopica, which is seen in Kenya and Ethiopia. Then you have the New World Leishmaniasis, which includes the L. chagassi, mexicana, amazonensis, brasiliensis, guiensis, panamensis, and the peruviana. For the sake of, at times those that go to exam, this may be relevant, but for the sake of this discussion today, the importance is mostly in the fact that some of these organisms have different sensitivity to some of the medications. So it's important we know which one we found where, And then also, if we look at the reservoirs, they can also differ. So when it comes to control, this knowledge is also important. Now, this is just a picture of what the sandfly looks like. The one on the left is the phlebotoman sandfly, which is what we have here in Nigeria. And the Lusmia is the one that we have in the New World, in transmission of the New World Leishmaniasis. Now, this is a picture showing the life cycle of Leishmania species. Beginning with number one. If we can see this is number one. Sandfly takes a blood meal. At this stage, it will inject a promastigot, what you call promastigot. If we can see them here, there are three flagellated organisms. It is what it injects into the skin of the human being. And the macrophages, which are present within the skin, sorry about that. The macrophages which are present within the skin pick up the promastigotes, and then they get transformed within the macrophages into the amastigotes. They mature and they rupture, they multiply, they rupture, and they move, and they rupture from the macrophage, and they move and get disseminated within the body. Now, if we look at picture number 5, the sandfly takes another blood meal. And when it takes this blood meal, it actually picks up this amastigote from there. And the amastigote will now enter the body of the sandfly, where it will get matured, and then it will now get back to become a promastigote, and which will now get back into the body. So this is how the cycle goes, from the sandfly and back to the sandfly. That's how the cycle for leishmaniasis goes. And as epidemiology, this is just to highlight again that these are the skin-neglected tropical diseases, of which number 6 is cutaneous leishmaniasis, and the aim is to control cutaneous leishmaniasis. If we look at number 8, this is also post-scalar azodermal leishmaniasis, which usually follows infection with visceral leishmaniasis, and this is also targeted for control. Now, this is a map trying to show the entire world and the incidence of cutaneous leishmaniasis in the whole world. If we look at it, there's a key for the map below, and those areas in green actually have no cases of leishmaniasis that are transmitted within them. The areas in gray have no data, while the areas in ash are not applicable. If you look at the left side, the key, the dark brown people, the dark program color signifies greater than 5,000, and then the maroon color signifies 1,499. But of interest is the white color, which shows 0, which shows no cases of cutaneous leishmaniasis. And if you look at the map properly, this is Nigeria, and we are white, meaning that we have no cases of cutaneous leishmaniasis. This data is because, this picture is because we do not report the cases of leishmaniasis that we usually see. That is actually a failure on our part, the clinicians who see it. Dr. Cole mentioned that it's more common in northern Nigeria, which is actually true. We see a lot of cases in Sokoto. Typically, it's very difficult for you to sit down and do clinic and not see 1 or 2 cases of leishmaniasis. And that's even because that's the tertiary institution. Most of the cases actually access care at the military hospital. That's the hospital within the military barracks, and also another state, the former leprosium, that's a state-owned facility. So there are a lot of cases of leishmaniasis. The gap, why we're seeing 0 of Nigeria here, is because we are not reporting them. This is one of the things that this lecture is supposed to address, so that we get to know it, and also know that we should report it, so that we have data, and those that are in charge of policy making can act on the data to help control leishmaniasis. Now, these are just some reports showing that truly leishmaniasis is present and is in Nigeria. If we look at this was since 1944, and that was the first report of 10 cases in Nigeria. We have reports in South where they said is an uncommon finding. We have reports from Kaduna in Nigeria. We also have reports from Plateau Jos. We have them. It's present in Nigeria. It's just that we have a problem. We're not reporting it properly. That, like I mentioned, common in northern Nigeria. For the people in the northeast, they report that a lot of, that's just discussion between us and them, not reporting in paper, that they have a lot of cutaneous leishmaniasis occurring within the military personnel that are posted to that axis of the country. And this is not far-fetched. This is because military personnel tend to be stationed within the forest areas, and they are more at risk of getting bitten by the sandfly. But leishmaniasis can also be worse. The manifestation may be worse in those with poor cell-mediated immunity, that especially patients that have HIV/AIDS. Now, incubation period of leishmaniasis usually is just a few days to about 2 months, and the lesion begins as a papule. That is a tiny solid rash. A papule refers to a tiny solid rash that is less than 0.5 or less than 1 cm, depending on which book you are reading, but suffice it to say that less than 1 cm. Now, it gradually grows, and then it now becomes, it will rupture and become an ulcer. And usually the ulcer is described as volcanic. It has a crater. We'll see pictures on the next slide. These ulcers may be single or multiple, but usually they're located on the exposed body area. So when you see multiple volcanic ulcers or craterform ulcers located on the exposed part of the body, that is usually a clue that you may be dealing with cutaneous leishmaniasis. But again, there is a catch. There are different forms of cutaneous leishmaniasis, as we'll see, and the clinical features may vary according to the species. That is why what looks like cutaneous leishmaniasis in Nigeria may be a little bit different from what looks like cutaneous leishmaniasis in India, which may be different from what you see in Brazil. The differences are subtle, but then they are also present. These are the forms of cutaneous leishmaniasis. We have the localized cutaneous leishmaniasis, the diffuse cutaneous leishmaniasis, leishmaniasis recidivans, post-sclerodermal leishmaniasis, leukoid leishmaniasis, and mucocutaneous leishmaniasis. This picture, except for this one on the left, all of these patients were seen in Sokoto. If we see what I'm referring to, you have an ulcer, and you can see that about the summit of the ulcer contains crusts. This is what we usually refer to as the volcanic nature of the ulcer. If you see, this one has a single ulcer, this patient has multiple ulcers, and also this patient, this patient here also has a single ulcer. So they usually present on the limbs, on the face, and on the arms. We rarely see it in other body parts. But if you look at this one on the left, I put it here so that we can see what early cutaneous leishmaniasis looks like. If you look at this picture on the left here, you can see that this is just a tiny papule on the hand. Then if you see this, this papule has started rupturing. With time, if left untreated, it will actually become like this before it will heal. So that's what localized cutaneous leishmaniasis looks like. This is the most common one that we see, and usually the patients that were presenting to us will not even remember when the exposure took place or where the exposure took place. They just come because they have an ulcer that has taken weeks to months without healing, and they're disturbed about it. The next patient has diffuse cutaneous leishmaniasis. Now, I think the people that are into the leprosy and TB control program will agree with me that this may look a little bit like patient that has leprosy, but this is actually diffuse cutaneous leishmaniasis. And the difference is with diffuse cutaneous leishmaniasis is you have multiple nodules, and these nodules do not rupture, unlike with localized cutaneous leishmaniasis. They do not rupture. They are closed, but when you biopsy them and you subject them to histology or staining, you might be able to pick
Dr. Abdullahi, sorry to interrupt you and interrupt a very interesting lecture. I just want to confirm that people are able to see the slides. Dr. Oiwo says he can't see your slides. I can see them quite well. So I just want to be sure that everyone can see the slides. So if you can't see the slides, please can you just say in the Q&A section that you can't see the slides, please? There's a Q&A section. The chat is not enabled because it's on webinar setting, but the Q&A, you can actually put a question if you have any questions or comments. Okay, you can. Okay, so I believe maybe it's just from someone who cannot see the slides. Okay, thank you. I just wanted to be sure because it's such an amazing and interesting lecture, and I wouldn't want anyone to miss any part of it. So please continue, Dr. Nafisa. Sorry for the interruption.
No problem at all. Thank you very much. So usually you see diffuse cutaneous leishmaniasis, they present with multiple lesions that are on non-contiguous body sites. When I say non-contiguous body sites, we're referring to you see somebody with maybe 2-3 lesions on the right lower limb, and then you see another lesion on the left upper limb, and then on the face. So you are seeing multiple lesions, and they're all on the non-contiguous body sites. That should raise the suspicion of diffuse cutaneous leishmaniasis. You see this lesion presenting as nodules that are not ruptured, intact nodules. That should raise the suspicion of cutaneous leishmaniasis, diffuse cutaneous leishmaniasis. If this patient is known to suffer from HIV/AIDS, that should also raise the suspicion of diffuse cutaneous leishmaniasis. Unfortunately, treatment of diffuse cutaneous leishmaniasis is usually difficult and ineffective. This is leishmaniasis recidivans. I apologize for putting the picture of a white person. I was not able to get a picture of leishmaniasis recidivans in a Black person, but it may complicate 3 to 10% of localized cutaneous leishmaniasis, and they present with brownish or yellowish papules at the border or within the scar of previous cutaneous leishmaniasis infection. Now, when you look at this face, you can see that there is a scar on the left cheek. And if you can see, if you look carefully, you see multiple tiny reddish papules. These are the papules, and they're at the edge of the scar. This is what Leishmaniasis recidivans looks like. And usually it is thought to be as a result of reactivation rather than a different new infection. So that is what Leishmaniasis recidivans looks like. Then we have post-Cala-Azar dermal leishmaniasis. This is usually seen in Sudan and in India. And they have different presentations. I'll explain the pictures later. And it usually presents months to years after treatment or resolution of visceral leishmaniasis. Remember, I mentioned that we have cutaneous leishmaniasis, we have visceral leishmaniasis. Visceral leishmaniasis is more common in Asia and Southern America. It's not so common in Nigeria, although there are reports of visceral leishmaniasis in Nigeria, but not so common here. So patients that have suffered from visceral leishmaniasis may, after a few weeks or a few months or even years, come down with cutaneous manifestations. Now, if it is the patient that is from Africa, they usually present earlier, a few weeks after resolution or treatment of the visceral leishmaniasis. As we can see in this picture up here, this is a child from Sudan, and if we can see tiny papules on the face, tiny papules on the face. So this is what post-Cala-Azar dermal leishmaniasis looked like in Africans. But in Indians, or in the Southern America, in India and Asia or Southern America, it actually doesn't look like that. It looks more like this picture on the right. You can see multiple hypopigmented macules on the back of this patient. And you can also see multiple nodules here on the hand of this patient. This is what post-Cala-Azar dermal leishmaniasis looks like in the New World, where you have New World leishmaniasis. Now, the difference may be because of the species. It may be something to do with our immunity, but the important thing is that for the Asians, for the New World, it usually runs a protracted course. But while for the ones in Africa, it usually runs a short course. So that's for post-Cala-Azar dermal leishmaniasis. Sorry, I think I'm going. So this is what leukoid leishmaniasis looks like. This is also another form of leishmaniasis. It's similar to recidivans, except that this is thought to be as a result of reinfection, not reactivation. It also runs an indolent and protracted course, and it actually looks like TB of the face, or rather lupus vulgaris. This is what mucocutaneous leishmaniasis looks like. Now, what happens with mucocutaneous leishmaniasis is that a patient will have their localized cutaneous leishmaniasis. They have a lesion on the face or on any part of the body, which now gradually sets the promastigotes now gradually get deposited on the mucosa. It could be the mucosa, or it could be the nasal, the buccal mucosa, even the genital mucosa. So it usually gets there and it destroys the area. It can result in septal perforation. The septum of the nose, it can perforate it and collapse of the nasal bridge, and that may make it look like lepromatous leprosy. But then there are also other features to distinguish, and then it can be secondarily infected. This can cause pharyngeal obstruction and respiratory failure. That is the problem with mucocutaneous leishmaniasis. Again, there are certain species that are prone to development of mucocutaneous leishmaniasis. And luckily enough for us, that was not what we see commonly in Nigeria. Now, if it's not cutaneous leishmaniasis, what else could it be? In dermatology, when we're thinking of mimics of a certain disease, we have to look at how each disease presented. We can see clearly that I just finished projecting pictures of the same disease condition, but different manifestations. So also the mimics can be different. So for mucocutaneous leishmaniasis, the mimics could be leprosy, it could be syphilis, it could be tuberculosis, deep fungal infections, many different things, vaginal malignancy, even nasopharyngeal carcinoma can look like that. Sorry. For diffuse cutaneous leishmaniasis, it may look like lepromatous leprosy, as we saw. It may look like deep fungal infections, xanthomas, or even lymphoma. But the most important one is the one that we commonly see, and that is what? The localized cutaneous leishmaniasis. And that may look like an arthropod bite. If you see that finger, that the person on the left that I projected, it may just look like something just bit him, and that's all. It can look like a Majochi granuloma, pyoderma, atypical mycobacterial or deep fungal infection, sarcoidosis, many different things. It can even look like a basal cell carcinoma or squamous cell carcinoma. While post-Cala-Azar dermal leishmaniasis may look like syphilis, may look like yours, and it may look like tuberculoid leprosy, or even sometimes lepromatous leprosy. Now, the problem is that for cutaneous leishmaniasis, you can hazard a guess, but the only way to say definitively that it's the cutaneous leishmaniasis, you'll have to run investigation. And those investigations are what will separate cutaneous leishmaniasis from all of these mimics. So this is just to give an idea of, okay, if it's not this, what else could it be? Now, the next slide is about how do you investigate a patient with leishmaniasis, cutaneous leishmaniasis. There are basically 4 things you can do to diagnose cutaneous leishmaniasis, but all 4 of them are tailored towards the same thing. We want to be able to visualize or to determine that the DNA of the organism, or rather, or even the organism itself, is present. That is all we're trying to achieve in the investigation. So direct presence of the organism is needed to say categorically that a patient has cutaneous leishmaniasis. And this you can do by one of 4 methods. You can do an impression smear, you can do a culture, you can do histology, and you can also do some molecular techniques like polymerase chain reaction. So this, so this is an impression smear. This is from a bone marrow of a patient. What you can do is you can do fine needle aspirate, you can do tissue scrapings, you can do skin biopsy, you can do skin slit and smear. Whatever you do, you take the sample, put it on a slide, you air dry the sample first for greater than 5 minutes, then you fix it with methyl alcohol, stain with GIMSA, and view under oil immersion microscopy. But this picture is for a bone marrow biopsy. We have the next one, which is histology. This is what you see. If you take a skin biopsy sample and you subject it to hematoxylin and usine stain, this is what you see in a patient that has cutaneous leishmaniasis. But the early lesions reveal macrophages laden with amastigotes, and these are called the Donovan bodies, while the late lesions will show leishmania granulomas. It depends on at what stage you get the patient. Then the next is you do your culture, and usually the culture can be done on the NNN media, the Novin McNeil Nicole media, or the Schneider's Drosophila media, which is supplemented with calf serum. This is a little bit slower than doing your smear. That you can do instantaneously in the clinic, and it helps to confirm the diagnosis, and you can now go ahead with treatment. While you have to do, you can also do a polymerase chain reaction. This has shown the most sensitivity and specificity in diagnosing leishmaniasis when you compare it with other methods, that is with the impression smear, with the biopsy, and with the culture. And it is able to detect leishmaniasis in healed lesions or otherwise difficult lesions. And such difficult lesions include things like patients that have leishmania recidivans, or patients that have diffuse cutaneous leishmaniasis. So you can do that. Now, at this point, I'll also have to point out to say that you should be able to do a speciation. You should know which species of leishmaniasis you are dealing with, because as I said, it has management implications. Now, there are some other investigations. Some will say, can you measure antibodies? There has not been much studies regarding antibody titers in patients that have leishmaniasis, and it's not really recommended as a way of diagnosing. There's an interferon gamma assay that has been developed, but this is not for clinical use. It's mostly for epidemiological use. And then you have the Montenegro skin test, otherwise called the leishmaniasis test. It looks like what you do with the Mantoux test in TB. You take the antigen, you inject it, and then after 72 hours, you read. If you get more than 5 mm in duration, then that is suggestive that the patient has leishmaniasis. The problem with the Montenegro skin test is that you cannot be sure whether it is present infection or previous infection. So that's the major limitation of the Montenegro skin test, otherwise called the leishmaniasis test. Now, this is just a way of summarizing the case, the clinical features, and also the investigation. These are some terminologies that the WHO came up with, where you have a probable case, you have a confirmed case, you have a cured case, you have a relapse case, and then you have treatment failure. A probable case where you have cutaneous leishmaniasis with showing clinical signs, but you do not have parasitological confirmation, and you do not have positive smear or culture. And for mucocutaneous, you do not have serological diagnosis. Now, this is usually what happens with us. We see so many of them, we don't usually bother to ask them to go and do a smear. And so we usually end up stopping at this level. probable case. That's not good for the patient because we do not have the species, and it's not good for the people that are waiting for our data because their data will be incomplete. So it's best to move on to a confirmed case, and that is you have your typical skin findings, and you also get your diagnosis done. And then you have a cured case where there is complete reepithelialization before day 45 of treatment. You have a relapse case whereby there's a reappearance of a nodule, plaque, or ulceration after cure. So the patient was after day 45 cured, but then there's relapse and there's reappearance of either of these three after cure. Then you have treatment failure. There's increase of a nodule, plaque, or ulceration within 14 days of treatment, or lack of complete reepithelialization within 45 days of treatment starting. So those are some of the terminologies that the WHO came up with for easier reporting of cases with cutaneous leishmaniasis. Now, how do you treat cutaneous leishmaniasis? To begin with, you want to know two things. Is it an uncomplicated case or is it a complicated case? Now, first is how do you know what is an uncomplicated case? And these are what they have come up with as the criteria for saying this is an uncomplicated lesion. So if you have infection with species not likely to be associated with mucosal leishmaniasis, you do not have any mucosal involvement, you have only a single lesion or a few lesions, you have a small lesion that is less than 1 cm, while some people say less than 4 cm, and you have an immunocompetent host. If you have these findings, then you have an uncomplicated lesion. But if you have these ones, any of this, if you have infection with source species associated with mucocutaneous leishmaniasis, this is usually seen in Bolivia, Peru, and Brazil. If you have more than 4 lesions of significant size greater than 1 cm, if you have an individual lesion greater than 5 cm, if you have subcutaneous nodules, regional lymphadenopathy greater than 1 cm, size or location of lesions for which local treatment is not feasible, if you have lesions on the face, fingers, toes, or genitalia, if you have an immunosuppressed host, or if you have clinical failure of local therapy after 2 to 3 months post-treatment, then you have what we call a complicated case. Now, to begin with, there is room for watchful waiting. If you have an uncomplicated case, you can actually decide, if you have this case, you can decide to just watchful wait. Usually it may heal within a few weeks to maximum, I think 4 weeks or 14 weeks, rather. If the patient is happy with that, you have to carry your patient along. So if the patient is happy with that and you have any of this, there's room for watchful waiting. You just wait and see whether it will heal. Now, if the patient is not happy with that, or you've done that and that has failed, then you now have to move to the second, what do you call it? The second, these options. And these are, you have the local therapy, and then you have the systemic therapy, which are the oral, and then you have the systemic therapy, which are the injectables. And the local therapy that you can do, you have sodium stibogluconate, you have meglumine antimonate, you have paramomycin ointment, and then you have paramomycin cream. Sadly, none of them is available. At least I've never come across them, and I've had patients who have gone to look for them. Some few patients were able to get sodium stibogluconate from Saudi, but we don't have it in Nigeria. At least where I've been practicing, I've not come across any of these patients, of any of these medications. So that's what you do for local therapy. If the local therapy fails, you can, or if you don't have the option, this is what we actually do. You can do oral systemic therapy, and this is when you have where you can use fluconazole or ketoconazole, or you can use miltefosine. Please, I would like to put a disclaimer here that ketoconazole has serious hepatotoxicity. So usually we shy away from ketoconazole and rather use fluconazole or itraconazole. If you look at the updated guidelines by the Pan American Health Organization, this is Southern America and North America, the Americas. They gave an updated guideline for management of cutaneous leishmaniasis in 2022. They actually specifically removed ketoconazole from their guidelines. So please, this is just because this is how this guideline came. I didn't want to tamper with it, but please, let's stay away from ketoconazole. We can use fluconazole, we can use itraconazole. My colleagues from the from the northeastern part of the country had used fluconazole with some success. We really didn't, the patients that we tried fluconazole for, honestly, didn't work much. We had to actually add other local destructive therapies to the fluconazole before we saw results. Now, the next thing is if you have patients that have complicated cutaneous leishmaniasis, then you can use any of this. The parenteral sodium gluconate, meglumine, antimonate, amphotericin B, liposomal amphotericin B, and pentamidine. The only one that is readily available, I think, is accessible is the liposomal amphotericin B, and also amphotericin B, the oxycholate. That's the only one that I've come across, but the other ones are also difficult to come across. So that's the treatment for complicated cutaneous leishmaniasis. Now, if you have a patient with, you don't have access to the drugs, like in our case, you have used something like fluconazole, it didn't give you any result, then there's room for destructive therapies. And the destructive therapies include things like cryotherapy, thermotherapy, or use of things like destroying high concentrated solutions like salicylic acid, like lactic acid. There's this solution called Colomac, and there's also room for use of high concentration of TCA. Sometimes you have to use both multiple modalities at once for you to be able to achieve cure, but we've used that with variable levels of success. Now, this is the complications that might arise from patients that have cutaneous leishmaniasis. To be clear, cutaneous leishmaniasis is rarely fatal. It's rarely fatal. The problem is that it is something that is disturbing. It leaves ugly scars, and then the money that it usually affects the poorest of the poor, the people that are actually I don't want to say neglected, but then the people that disadvantaged in the society. They have money, the money they have, they're trying to use it to eat, and then they now have to use money to get drugs. The treatment takes a long time, and the drugs can be difficult to get. So money is being diverted from feeding to treatment. So that's the problem with cutaneous leishmaniasis. Except for few, we've had a patient that had diffuse cutaneous leishmaniasis, that it was really horrible and the whole body, but except for very few, it's not fatal, but then it can be a cause of protracted illness, visit to the healthcare facility, and it can be disturbing to the patient. The most worrisome problem we usually have is superimposed bacterial infection, which usually you can treat with antibiotics. It can disseminate and result in mucosal leishmaniasis. As I mentioned, not common in Nigeria. It can recur in cause leishmaniasis recidivans. It can form scars. The scars of leishmaniasis actually don't look fine at all. If you see a patient with the scars of leishmaniasis, they're horrible. They are so big, ugly, with atrophic skin and all of that. For women, especially, it can be quite disturbing. And when it occurs on places like the face, you can just imagine carrying such a scar all your life. And for patients that have mucosal leishmaniasis, there can be destruction of the upper respiratory tract. Then there's also stigmatization and disability. Imagine some of the pictures that I showed, and that can, if a patient that has this, they usually enter the society and people usually shy away from them. So that could be a cause of stigmatization. And depending on the location in the body, it can actually be a cause of disability. So this being an infectious disease, this is one of the ways in which it can be prevented. You can do environmental modification. Usually the sandfly lives in crevices or wall crevices or in the bush. So if you can clear distance away from your environment, that should reduce the number of sandflies in the environment. Vector control through spraying might also help reduce the number of sandflies. Use of protective clothing and insecticide treated nets can help to protect one from getting a bite from the sandfly. Then identification and treatment of reservoirs of infection, both animals and human reservoirs. If they are identified and treated early, that could also limit where the sandfly can get the infection from to go and spread it to other people. And early and effective treatment of infected individual will also help to reduce the reservoirs of infection. So those are the ways that you can prevent it. Now, part of the important thing about this discussion is we realize that there's a problem. We're seeing these things and we're not reporting them. So the policymakers cannot actually make any policy. We can't make a case to the government that, oh, government, please supply us this drug. We need sodium stibogluconate. We need topical palomycin. And the government will now say, oh, why do you need it? Because we're seeing cases with leishmaniasis, but there's no data to support this claim of ours. So we want us to, after this lecture, to be able to identify cutaneous leishmaniasis, to be able to diagnose cutaneous leishmaniasis, and to be able to report cases of cutaneous leishmaniasis so that we can have data and we can work towards controlling or at least eliminating or at least controlling cases of cutaneous leishmaniasis. So how do you go about that? This is for health workers. So I believe that people listening to me there are different cadres of health workers. So some will be working in tertiary institutions, some will be working in secondary, some will be working in the primary healthcare centers. And then depending, again, the primary healthcare center might be in an urban area or might be in a rural area. So wherever you are, this is where it begins, in the health facility. So the health facility, that is where the patient will come to, or on rare cases, you might have gone to the community to do an outreach program and you pick patients from the community, or the community is so well enlightened that they know that this is cutaneous leishmaniasis, so they visit the health facility. In Sokoto, they call it Bakondauri. They even have a local name for it. They call it Bakondauri. I think the Northeastern people also have another name for it. So wherever it is coming from, whether it's the community or the health facility, there's an assignated person in the local government who should get the data from the health facility. And then this person from the local government will work together with the laboratory. If the diagnosis is confirmed, then it is now taken to the state epidemiologist. And then at the state epidemiology, it's moved to the national epidemiology. Then the reference laboratory will help in also doing a speciation, and then the data can be utilized by the national team and also with other partners in the management of leishmaniasis. So this is how it is supposed to go. So if after today we see any cases of leishmaniasis at our health facility, we should be able to alert a desk officer within the health facility who will contact the local government, assignated person from the local government, and then the flow of information will go upwards. That is what we are supposed to do. I put this as a picture of what the form for reporting looks like, but this is not specifically meant for cutaneous. Sorry for the tiny writing. It contains some information, but it's not that you're going to fill, including the date of birth of the patient, the address, the symptoms that the patient presented with, also the phone number, vaccine status of the patient, and things like that. So this is just a general, it's a general thing. It's not specific for cutaneous leishmaniasis. They usually use it for reporting cases, but part of the impact of this lecture should be that we should know how to use this particular form and how to report all those cases. So this is, I think, the last thing. Oh, this is just a picture trying to show how to integrate management of skin neglected tropical disease, right from the individual level to community level and the tertiary institution, and the role of every person or every level of cadre of healthcare. So wherever you might be, whatever level, whether you're at in the primary healthcare center level, the secondary healthcare center level, or the tertiary healthcare center level, there is a role to play in the management, in identification and management of patients that have cutaneous leishmaniasis. Sorry about this back and forth. These are my references, and this is our objective, skin health for all. Thank you for listening, and then we entertain questions, comments, and contribution. Thank you.
Awesome. Thank you so much, Dr. Abdullahi. That was very, very elaborate, and the slides were quite visible. And I'm sure everyone has learned about cutaneous leishmaniasis. We may have some questions, I'm sure, in the chat box. I'm going to go into the chat box. So when we were, preparing for this particular topic, we actually discovered that leishmaniasis is actually, maybe that's one reason why we're not reporting cases. But it appears that leishmaniasis is not on the NTD list for skin NTD list for Nigeria, and I was quite surprised. I looked and searched, and I was like, oh. it seems like maybe it's been missed out, and maybe the reason is because of what Dr. Abdullahi has said, that we haven't been reporting cases. So I think by the time we start reporting cases, the government officials and the NTD program will begin to realize that we actually do have cases of leishmaniasis that require monitoring, surveillance, and control. So I'm just looking through the box to see if we have any questions, and you can also check through Dr. Nafisa. While we're doing that, I'd just like to give a very warm welcome to Dr. Claire Fuller, who I believe is also on the call. She is the medical director, the chairperson of the International Foundation of Dermatology, who actually gave us a grant to have this program, to have this webinar series for skin NTDs. That was given to the Nigerian Association of Dermatologists. And we are very happy to be able to have the opportunity to engage ourselves and our colleagues from across the country to, join our hands in the fight against skin NTDs. As mentioned, they do have a major impact on quality of life of people who have this, and they're usually found in people who can't really afford, their own treatment. And we really want to do more to help and to be able to control and eradicate these diseases in Nigeria. So I don't know if Dr. Claire Fuller would like to say one or two things, or if you have any questions or comments for us. I believe she's here. Maybe you can stop sharing your screen, Dr. Abdullahi. Then we have some people whose hands are raised. So after that, I will probably allow you to speak for a few minutes. Let me try to enable Dr. Okay. Yes.
Hi. Thank you very much for spotting me. It was a lovely accident. I was just following you on Twitter and saw the advertising for that. So well done. It works really well.
Thank you.
Just congratulate you on this initiative, and to say I can share this initiative with your permission at the WHO. We've got a skin NTD meeting at the end of March. And this is a fantastic tool, an educational tool. And I'm really excited to be joining you on the call. So well done. And I think you're going to run a series of these. I can't remember how many you're doing, but
yes,
congratulations, and it's great to join you.
Okay, thank you so much. Thank you very much. Yes, so let me just look for those who have raised their hands, who would like to say one or two things. I've looked through the chat box to check for questions, but most are just comments. So
there are some few questions, but
okay.
But should I go ahead, or do we start with the people that
let me just see if I can, so we can make it interactive. Olubumi Salami, you're unable to speak. You raised your hand to say something. Are you there? Okay. We also have Ibrahim Yusuf. Would you like to say something? I think you are able to speak now. Or if you just have any questions or comments, you can always put them in the chat box and we will answer.
Okay. Thank you for all the comments and questions. Mr. Paul asks that I want to suggest that more researches be conducted and communicated to policymakers as far as leishmaniasis is concerned. Thank you very much for that comment. There's actually a need for that. And I think after this should spark interest in many of us to come together and see what we can come up with. Now, who knows whether it's present in other zones in Nigeria? There's a report I shared about a case in South Nigeria, but not very common. I remember a time in Ibadan where I trained. Everybody was so excited when there's a one case of cutaneous leishmaniasis, but then there might be, because of the free mobility of movement within the country, I'm sure there are people that will come from the north, pick it and go to the south, but it wouldn't be as common. It's not as common in the south as it is in the north. There is a question on leukoid leishmaniasis. I think Mr. Onwawulu or Seniguan asks that, can you kindly talk more on leukoid leishmaniasis? It's actually a very rare type of leishmaniasis, and it's usually due to reinfection, mostly affects the face, and the patient who present with facies that actually look like patients that have lepromatous leprosy. The diagnosis and the treatment can be a little bit challenging. It's not as amenable to treatment as the localized cutaneous leishmaniasis. I think medical laboratory scientists, this is Mr. Ademola Fasanu. I think medical laboratory scientists should be invited, especially in the area of conducting investigations. Please, medical laboratory scientists are free to attend. This is for all healthcare workers. We need them to be on board with us, and if we are to achieve the target of control of these diseases. So they are actually invited. I know at least one or two of them that reached out to me, and I told them that they are welcome to join these lectures. When it comes to conducting investigations, we actually work hand in hand with them in our hospitals. Then Mr. Bashir Usman is asking the difference between Donovan bodies from leishmaniasis and those from Calinobacteria granulomatis. Honestly, I don't know the answer to this question, except that I know that Donovan bodies, the leishmaniasis, you actually need to see kinetoplasts to be able to say this is actually cutaneous leishmaniasis. So that might be the difference. Maybe the medical laboratory people will be able to shed more light on that. Then, is there any chemoprophylaxis for leishmaniasis in Nigeria, just as we do for onchocerciasis? No, not to my knowledge. There is no, not even in Nigeria. I didn't come across any chemoprophylaxis program for leishmaniasis anywhere in the world, not only for Nigeria. I don't know, I may be mistaken, but I didn't come across anything like that. Then thank you. My question is, what is the advantage of local therapy over systemic therapy? Oh, the advantage of local therapy is that it is less toxic. The systemic therapy can be actually, they have a lot of side effects. Those drugs have a lot of side effects. So if you can do local therapy, it's better. You limit the side effects of the drugs, and then you tend to achieve what you want to achieve. That's the cure. Then can we get the slides after the presentation? I'll do some editing of the slides, remove some pictures. I used some pictures that I actually did not have the permission to use, but that's just for the what do you call it, for education purpose. So I'll remove some of the pictures before I share the slides. So sorry about that. If you want to see the pictures, you might have to look at the recording of the webinar, not the slides. Back on the row is not in Sokoto. We call back on the row back on the cutaneous leishmaniasis. I don't know in other parts of the world. Dr. Ahmed Kolo Olejimo, to what extent is cutaneous leishmaniasis self-limiting? When should we intervene? We should intervene when we have any feature that suggests that this is complicated cutaneous leishmaniasis. If we have uncomplicated cutaneous leishmaniasis, then we should intervene if the patient wants us to intervene, which means that even though we know that it may heal on its own, but the patient doesn't want to wait, then we should intervene. Otherwise, we can wait, and then or if we have any complicated complicated leishmaniasis, then we go ahead for treatment. Is it possible to have co-infection or superimposed infections in cutaneous leishmaniasis? I don't know whether in microbiology there is a difference in this terminology, but what we usually say is we have superimposed infection, and it's not even very common. To be very fair, it's not very common, but that is the most common complication apart from scarring that we come across. But what we have is super infection. Then is there any laboratory test done to establish the diagnosis? This is Lawal Muhammad Abakar. Yes, those are the investigations I talked about: the impression smear, the histology, the culture, and also the molecular studies, which include the polymerase chain reaction. Sorry, I think somebody is volunteering here. Abubakar Alhaji Musa, that Northeastern people call it Sadawari. So thank you, Mr. Onwala, I hope you'll be able to recognize cutaneous leishmaniasis wherever you come across it. What is the prevalence of cutaneous leishmaniasis in Nigeria? And anonymous attendees asking this question. To be very fair, I wouldn't know. We do not have national data regarding cutaneous leishmaniasis. We don't. And that's why the WHO map I projected earlier was saying that 0 cases in Nigeria. We don't have data regarding prevalence of cutaneous leishmaniasis in Nigeria. But I think the study that was done in Kaduna and Plateau were reporting up to, I think in Plateau, they did a house-to-house survey. They were reporting around between 16 to 20%, but we do not have national data regarding prevalence of cutaneous leishmaniasis in Nigeria. We don't. What are the success rate of antifungal over the antiparasitic drugs, especially that the former are more readily available than the latter? Like I mentioned, personally, our own experience was that the antifungal drugs like fluconazole that we used did not work. Rather, we had to now add destructive therapy using Colomax solution before we were able to achieve some good results. We waited for like 3 months. That's 12 weeks. Usually with the antifungals, you see treatment. You see results earlier than that. But people from the Northeast, doctors from the Northeast, when we converse, they say they have had good results with antifungal therapy. That's using fluconazole. Now, like I mentioned, the antiparasitic drugs are not even available, so it's even difficult to say that we are having any comparison. They're not readily available in this environment at all. So it's either you do your antifungal medication or you do destructive therapy. Now, there is this thermotherapy, which has been approved for management of cutaneous leishmaniasis. Thermotherapy, there are thermotherapy devices and approved by the FDA, United States, but they're not here with us. We do not have them. What we rather do is we have a crude way of doing thermotherapy. That's, please, this is just a crude way of doing it. We're trying to improvise. So it's not as if I'm saying anybody should go and do that. This is just us as specialists, just sometimes at the end of our test, are just trying to see what we can do. And we ask the patient to get a metal iron, put it in the what do you call it now? In the fire. When it's red hot, they should get it as close to the lesion as they can without touching the lesion, and they should do that repeatedly. This is not a standard scientifically proven. It's just trying to get heat towards the protozoa, but they're actually thermotherapy devices that are used. But this is again not available in our own setting, so we do not have comparisons.
All right. Okay, may I just say that we could maybe answer some of the other questions on the chat box by typing. I would like to call on Dr. Folayan. I think Dr. Oiwo has mentioned that he's part of the NTD program, National NTD program, to share his thoughts and his experience on leishmaniasis and correct some things, because even though in most of the data, most of the documents we have, leishmaniasis is not there, but he says it's there, so we need to know. And then I also am going to share my screen to talk about two apps that we can use, so that if we do see a case that we suspect maybe leishmaniasis, we can actually check these apps to help us, to guide us, to remind us about the features of leishmaniasis, so that it can help us with diagnosis. One app is produced by the WHO, and it's online on the App Store. Unfortunately, you can't get it on your webpage, but you can get it on the App Store. So this is the Skin NTDs app by the WHO. And you can download it on your phone. If you have a smartphone, an Android phone, it talks about all the skin NTDs, and there's a guide to the diagnosis of each of those skin NTDs. So you can download this on your phone. If you practice in a place where you may be seeing some of these cases, it will help with helping to make a diagnosis. What are the features you're looking at? You can see here cutaneous leishmaniasis, lumps, ulcers, swollen limbs, patches, and some of them have pictures. So it's helpful, as a reminder and as a guide. Now, the other app is one that we are developing locally here. That app is called Densa, and we're trying to work on it to develop it to the point where, you can actually reach out to a dermatologist. Let me just get the proper website address. And you can send a photo to a dermatologist and they can say, okay, we think this may be leishmaniasis. Why don't you, take these steps? And so we're going to be introducing these two apps in this program to enable us as health workers to, make better or to begin to diagnose some of these conditions that have gone undiagnosed or misdiagnosed for a very long time. So aside from the lectures, we want people to actually practice using these apps in their places of work, and if they have any questions or comments about the app, we can always discuss them during the webinar. So let me just go to Densa app so that I can show you what it looks like and see if we can look at that. So Dr. I don't know if you're on the call. Dr. Afolayan, I think I've enabled Dr. Afolayan to be a panelist. If he's here. So I don't know if you can see my screen. This is the app. It's a very, very straightforward, simple app to use. And in this place, you can actually put your name, your email address, your location, the symptoms, and there's a place where you can upload a photo and send. And this photo will be reviewed by a dermatologist, and the dermatologist will be able to tell you, yes, this may be leishmaniasis, or this may be something else, and then could help with next steps to diagnosis and where you can actually refer the patient to, if referral is required, or if or when referral is required. So Dr. Oiwo, are you on the call? I don't know whether you want to add anything. So I would advise, if you could download the WHO app on your phone and have that as a guide. And then we'll also be working with the Densa app on this series and see whether it can be useful or helpful as a guide to helping people with diagnosis of various skin conditions by reviewing with a specialist. Thank you.
Dr.
Okay.
Cole.
Okay. Yeah, sorry, this is Afolayan Gabriel.
Okay, good afternoon.
From Federal Ministry of Health. Thank you so much. I was hoping that the national coordinator would be on the call, but as it is like, is not, but I'll just say one or two things and probably also seek for more engagement with the national NTD program. So yes, Leishmaniasis is one of the NTD program in Nigeria. We have a desk officer for it. He's a lab scientist. His name is Mr. Shilo Paul. I can drop his email and as well as his phone number so that we are all together to improve both case finding, treatment, and proper management of cases of leishmaniasis. So I'll say generally that yes, mapping has not really been done nationwide to determine the prevalence of leishmaniasis in Nigeria. But if you get a copy of the new NTD master plan that was launched, I promise to share the soft copy with your colleague who is in touch with us tomorrow. You can go and see the situation analysis that was documented, as well as activities that the national NTD program has put in place for the next 5 years forced to improve or to concentrate on mapping these diseases using integrated approaches. We don't want to go and map leishmaniasis, go and map rabies. If we have experts around that we can sit together, probably come up with a tool that can help us, dictate more of these skin NTDs. Yes, we are aware of the WHO app and all of the resources available, but there is need to engage with the national program. I'm sorry, I joined very late, so I didn't really get to see the full detail of diagnosis, referral that our excellent doctor Ajay talk about, but there is a pathway, there is protocol, there is procedure to which leishmaniasis can be reported to the national office. I'm not prepared to deliver the lecture on that. I just also want to learn, I came to learn on the call, but I will suggest that who the organizer of this leishmaniasis webinar should, as a matter of urgency, get in touch with the desk officer at the national office so that all of the information that you're turning out in the public can be synergized. So you have really get to know what the national priorities is and the way program is to be run. And then we can all work together so that we can, dictate more cases and serve the people who are done with leishmaniasis and other skin NTD program. So just a recap again to say, yes, there is a national program for leishmaniasis. We have a desk officer for it. I will drop his email and his phone number. I would suggest before the next call on this subject, just a call through, you can rub minds with him. He's in better position, to tell us what it is and how far they've gone in this program. And most importantly, how we will implement the new NTD master plan together, leveraging on the expertise of everyone within the field. And I think that will help us to achieve more. So thank you and a good job. Well done. We appreciate what all the stakeholders are doing to really give more visibility to NTD program in Nigeria, and it can only get better. So thank you. That would just be my thought for now. I'm not engaged to speak officially. I just also come to learn, but since I'm in the program and I know things are actually going on in that area, I think it's good to say one or two things. Thank you. Yeah.
Thank you. Thank you very much, sir. We are so grateful for your, very, very robust contribution. I will definitely be engaging. That's one of the aims of this webinar, is to engage, our policymakers and policy leaders and collaborate with clinicians and health workers from the grassroots to the teaching hospitals so that we can actually all work together to achieve great results in the control of some of these skin NTDs. So Dr. Oiwo, who is one of our facilitators and also the NTD chairperson for the Nigerian Medical Association, he would like to say a few things as well. And we'll still continue to try to answer the questions in the chat box. And if we have any extra time at the end, we can continue the Q&A live. Thank you so much.
Thank you, Dr. Cole. And I want to appreciate Dr. Abdullahi for that excellent presentation. Let me, as a matter of importance, extend the warm greetings of the President of the Nigerian Medical Association, Dr. Uche Ojima, who incidentally is also a dermatologist and venerologist. He extends his greeting on this program, on this webinar series. As we were told at the beginning, it's a bi-monthly webinar series that will extend for 6 months. during which we expect to rub minds, just like we have today. And it's been interesting with the feedback. Let me also especially appreciate Dr. Claire Fuller for her presence. It's important to have such a forum like this where stakeholders can rub minds. I've scanned through the Q&A session, and I can see so much interest of everyone trying to raise more awareness and the needed action on leishmaniasis. I want to thank the last speaker from the Federal Ministry of Health. I've been having quite a robust discussion with him, and I want to thank you so much, sir, for all your very warm regards. Dr. Akpan, actually, who is the National NTD Coordinator of the Federal Ministry of Health, had given his words that was going to come in, though he had earlier stated that he had another meeting. So we're hopeful before the end of this meeting may be able to get in. Professor Osifo as well, who is the president of the Pharmaceutical Society of Nigeria, who has been very, very fantastic in his support and collaboration for this program. Also had promised to join, but is engaged at the moment, and so is unavoidably absent. But I can see pharmacists who are here on the call, and from the comments, I saw a question about what's the role of the pharmacist. Just like Dr. Cole mentioned at the beginning, we appreciate the role and the importance of the community pharmacist who, as we know it, these patients get to see them at first. So with this presentation, the necessary alarm can be raised, one, in terms of where the confirmation or the diagnosis will be made, with direction of the patient to the right place. Then, of course, in the area of the chemotherapy, when that becomes quite extensive after the ideal mapping and other necessary protocols according to the program, I'm sure the pharmacists will be very, very important in this area. In the area of research of available drugs that are useful, that are already available outside the country, or even indigenous drugs that we can use after the needed scientific validation of those drugs. The pharmacists are very, very apt in this area. So I want to thank Dr. Cole for this opportunity. And to just wrap up, leishmaniasis is also called the flesh eater's disease. And if we look closely, we would also find that clinically, they tend to have some features with even lupus vulgaris. They tend to have some features with quite some other cutaneous infectious diseases. And from some of the pictures that we see, we realize again that the early phase of the presentation may also even look like tinea corporis. Some may even say tinea fasciae. But again, this program would, this webinar series would help us know what next to do when we see such patients. So once again, thank you so much for coming, and to remind us again that 2 weeks' time would be the next session. Thank you, Dr. Cole. Over and out.
Thank you so much, Dr. Oiwo. Thanks a lot. So I'm just trying to go through the charts to see any questions that we haven't addressed. Someone asked a question about the last webinar. We spoke about some WHO online courses as well on NTDs. So I've sent her the link, but if you go on your browser and click on openwho.org, you will find that there are a lot of free online courses on NTDs, run by the WHO, and they can also be helpful if you're interested in further learning about NTDs. So if you go to Open WHO, it may be difficult to send to everyone's email. We have over 800 people registered for this course. So we will try to send emails to everyone, but if we're not able to do that for the links, all the links, they will definitely be added, onto the recording, because we're going to put all the webinar series on YouTube. So we'll add all those links to the YouTube caption so people can actually get the information from there. So we'll just say we'll share the YouTube link, and most of that other information will be available in the caption. But Open WHO has a lot of free online courses on NTDs, on various NTDs, as well as treatment and control. So that's also a useful resource if you're interested. The Densa app, we are still developing it. It's not yet on the App Store, but before the next webinar, it will be on the App Store. So it was locally designed by our team and, a software developer, and, we're still refining it so that it can work in a local setting. We need to also collaborate with, the DSNOs and the NTD program managers so that it's functional for everybody. You can also make reports on the app, actually. And that's one of the things we're trying to include. So before the next webinar, it will be on the App Store. However, it's already, if you just go type in the web page link, it's uploaded, and you can, try to use it to make reports and send photographs. It's called Densa, DENSA, Densa app. So we'll be using a lot more of it during the course of this program. So thank you very much. I think we have come to the end of the program. If you have any other questions, we can also respond to them online, maybe in the next 5 minutes before we wrap up. Yeah, Dr. Nafisa, I don't know if you have any other thing you want to share before
Thank you very much, Dr. Cole. I was busy trying to answer the questions, but it's impossible to answer them all. I've tried
quite a lot.
So many questions.
We had over 350 people. So many people are very interested, and the attendance has been encouraging. So we hope we'll have more people.
Thank you very much. The only thing that I wanted to add was that, interestingly, in the research, I didn't put it in the slides because I didn't come across it in any of the guidelines, but interestingly, there's some research that showed that intralesional, when we say intralesional, it means injection of the lesion with hypertonic saline has yielded good results. There are some few reports about that, so that might be worth exploring. Hypertonic saline is something that is cheap, easily done. So that might be a potential research area for people. I saw some 2-3 reports about that. So it's something that might be worth exploring, but I didn't put it in the slides because it was not part of the guidelines. These are just reports by some people.
And sometimes we may actually need to develop, therapies that we can afford in this environment that, are low cost but effective. So there is also a place for a lot of research, for those who are interested in research, to be able to think of, good and ethical research protocols that we can try and then report our findings internationally.
Yes, thank you.
Thank you very much.
Dr. Cole.
Yes.
Sorry, to also add that the aim of this webinar series is to raise awareness, get more collaboration. I think that wherever we work, in whatever part of the nation we are, whichever of the disciplines among the health profession that we work in, there's almost always a primary health center in the list close to us. And I know that there is a link of communication with the Federal Ministry of Health with respect to the flow of information. And that is why this lecture is quite apt. Once we see any of the NTDs, we should not just make the diagnosis and keep it in our primary health center, hospitals, either government or private. We should make attempt to notify the nearest focal officer for NTD in the local government. Usually every state has a state coordinator, and in every state there are local government NTD focal officers that we can link ourselves with, and these persons would send this information to the state NTD coordinator, who would also liaise with the zonal units, then the national program. There are usually appraisals that are done on regular basis, and that also is another way we can ensure adequate flow of information. Another thing is for us to break the silo of knowledge, break the silo of ingenuity, break the silo of capability in the diagnosis and management of NTDs, no matter the discipline you are in the health profession. Everyone has to play a role in making sure that the 2030 target of the Sustainable Development Goal for NTD is achieved. So this is just a very good way to start. We hope to build on this subsequently. Thank you.
Yes, thank you so much. So a few questions just to try to address briefly before we close. Some people had asked, I mean the last few in the chat, Polycarp Danjuma said, as a community health practitioner, are these healthcare providers in the community? What's the position of this group of service providers in the diagnosis, since it seems very complicated? So now what we are trying to do is try to make people be aware of, have an idea of what it looks like. And if you're not sure, you can use the app that we've spoken about, or you can take a photo and send it to the Densa app so that we can say, oh yes, we think this could be the leishmaniasis, and then we can direct you appropriately. Now, another piece of information that we'll be sending to you are how you can get information about the NTD, local NTD person in your local government or in your state, so that if you do have any case of a suspected NTD, you can actually reach out to them via text message or email, and it can be followed up. So those are some of the things so that the cases can be properly reported. Most people may not have access to the reporting forms, but at least if you are able to recognize it, that's the first step, and you know who to send the information to, that's the second step. That is the same for community pharmacists. If somebody comes into your store to buy some medication for some kind of ulcer or rash, you would know that, yes, this, you shouldn't just give them medication, but you should actually maybe take a photo of it and send to us. And then we can say, we think he should be referred to this place or that place for further review and also for reporting. So those are some of the ways that you can get involved in us being able to capture these cases and also be able to treat and report them appropriately. So thank you everyone for joining, which was a very good session, and we look forward to the next session, which will be in 2 weeks' time. So please continue to be a part of this. We're going to get certificates at the end of the course, and of course, you'll be a lot more informed about NTDs and become NTD champions in your various communities at the end of this program. Thank you very much and have a blessed evening. Bye for now. Bye-bye.